Good evening, everyone. Thank you for joining us tonight for our educational webinar on the latest myeloma research updates from ASH 2019, from the ASH 2019 annual meeting. My name is Gabriele Colasurdo. I'm the Manager of Education and Patient Services at Myeloma Canada. We're happy today to have Dr. Sita Bhella, a hematologist from Princess Margaret Cancer Centre in Toronto, who will be presenting this webinar. Before we get to Dr. Bhella, I just want to go through a few things with you. So just know all of our webinars are recorded and they're available on our YouTube channel, as well as on Myeloma Canada's website. Now, so of course, if you would like to go back and review some of the slides, you can always do so after the meeting. Usually takes us a few days to post it, but you should expect it probably by the end of the week, available on the YouTube channel. If you have trouble seeing it, you can always email me, and my email can be found on the Myeloma Canada website. So from YouTube, you in the search bar type in Myeloma Canada. Click enter or on the search icon, and you'll see a list of channels. You just click on our channel and you'll be able to see our videos. There's also a subscribe button here. If you subscribe to our channel, whenever we upload a video, you'll get a notification. So that's a good way to not miss anything. From our website, click on the resources button at the top of the website, myeloma.ca. A drop-down menu will drop down, and you just click on educational videos, and that will send you off to our YouTube channel. Next, before we start, I just wanted to inform everyone how they could ask questions. So to ask questions, on your GoToWebinar software, you'll see there's these little tabs. If you click on the triangle here, that says questions, this box will open up and you can type your question here and click on the button send. Once you've clicked on send, I will receive the questions, and I will read them to Dr. Bhella, and so forth. So without further ado, I'd like to thank Dr. Bhella for coming here and for joining us tonight and presenting the latest research updates from ASH.
Thanks, Gabe. And I just wanted to say hello to everyone. And thank you for inviting me to do the webinar today. And so I'm Sita Bhella. I'm one of the hematologists from Princess Margaret. And I'm very privileged to be here today to chat with you about some of the latest myeloma research updates from the ASH 2019 annual meeting, which is our largest hematology meeting. And so we'll just move on to the next slide. Yeah, and so these are my disclosures. So I've been a consultant and have had speaking honorariums and scientific advisory board disclosures. And to the next slide, this is our agenda. So today we're going to go through some common terms with respect to myeloma. Then we're going to go through highlights of the latest research in hematology, focusing on 5 major areas. So patients who have been newly diagnosed with myeloma and are transplant eligible, the latest research for those who have been newly diagnosed and are transplant ineligible, some agents for relapsed refractory myeloma. We'll look at some of the newer immunotherapies out there, looking at CAR T-cell, as well as other therapies and other agents and combinations. And then we'll have some time for questions at the end. So the next slide that we'll move on to here is, oops, I'm gonna go back one, is common terms. So as you've probably heard from your hematologist or oncologist, many chemotherapies have 2 names associated with them, and they often have a letter that's associated with them. Sometimes that is not at all related to the name of the drug, and that can sometimes be confusing. So when you see the letter V, think of bortezomib or Velcade. R stands for lenalidomide or Revlimid, P for pomalidomide, K for carfilzomib, I for ixazomib, D for daratumumab, a small d for dexamethasone, Cybor-D, which is a very commonly used regime up front in myeloma, which stands for cyclophosphamide, bortezomib, and dexamethasone. That's commonly used upfront in the transplant eligible. And BCMA, which stands for B-cell maturation antigen, which refers to kind of like an address marker of the myeloma cell. So if you picture a myeloma cell as being lined with little proteins or antigens, one of them is something called a B-cell maturation antigen, and it's specific to myeloma cells. So if we have a targeted drug attached to that, that can help target myeloma cells. And we'll talk about that in a little bit. Some other common terms, so PFS stands for progression-free survival. So we're aiming at trying to increase progression-free survival as much as possible with new therapies. Overall survival, we're aiming to increase as well. Median is the point at which half of the patients have reached the outcome. Minimal residual disease is an emerging concept where we measure how much myeloma cells are present compared to normal bone marrow cells. And it refers to when myeloma cells are below the limit of detection, and generally that's 1 myeloma cell per million bone marrow cells. There's various ways of measuring this. And induction is a treatment aimed at killing as many myeloma cells as possible. Consolidation is a treatment after initial therapy. And maintenance is a prolonged low-dose form of treatment that's aimed at prolonging remission in a way that reduces toxicity. So this year, our annual meeting was in Orlando, and we have a picture of Minnie Mouse and Mickey Mouse as we were located near Disney World. And it was a great meeting as there were many advances in myeloma that are quite exciting. And I'm quite excited to be able to present these advances to you. And in the last couple of years, there have been a significant number of new agents that are available in myeloma care that weren't available a few years ago. So there's been a real explosion in terms of novel therapies. So on that note, we're going to take a look at new treatment combinations that were presented at ASH, so the newest research, for patients who are newly diagnosed with myeloma and are eligible for a transplant. And by transplant, we mean auto transplant, where you are receiving your own cells after receiving high-dose chemotherapy. And patients who are transplant eligible are generally those who are younger, so generally below the age of 75, and it's not so much based on age, but your overall fitness. And so what these trials that we highlighted here today look at are the addition of daratumumab to some standard of care options. So as we spoke about earlier, Cyborg-D is a chemotherapy option that's used in many places around Canada as frontline therapy for those who are transplant eligible. What the LYRA trial looked at was adding a drug called daratumumab, which many of you may know is a drug that attaches to CD38, which is another kind of address on the myeloma cell, and it directly targets it in combination with bortezomib, cyclophosphamide, and dexamethasone. And then after the patients received the induction therapy of Dara plus Cyborg-D, they then had a transplant, and then had maintenance daratumumab once a month for 12 months. And what this trial found was by adding daratumumab to our standard of care Cyborg-D, that improved overall responses. And at the 12-month mark, there's an overall survival rate of around 98%. More follow-up data is needed in order to determine the overall survival in a longer period of time, but it looks quite promising in terms of adding daratumumab upfront to Cyborg-D and then using daratumumab after a transplant. We're going to take a closer look at the Griffin trial and the Master trial in subsequent slides, but they also look at adding daratumumab onto backbones that are used commonly upfront in transplant eligible myeloma patients. So In some jurisdictions, you may see Revlimid, bortezomib, dexamethasone, or RVD used up front. And then in the Griffin trial, they added Dara up front to that. And in the Master trial, they added to Revlimid, dexamethasone, carfilzomib, and daratumumab up front, which showed that there was a significant rate of MRD negativity. There was also a trial that looked at adding daratumumab to ixazomib, lenalidomide, dexamethasone. Ixazomib is a similar class of drugs as bortezomib. They're both proteasome inhibitors. And this regime was well tolerated. It didn't impact stem cell mobilization, which refers to the collection of stem cells that you need to have done in order to go ahead with a stem cell transplant. So I guess the key take-home point, there were a lot of upfront daratumumab trials in addition to some standard of care induction regimes. So let's take a closer look at the Griffin trial and the Master trial. And so the Griffin trial, we often have diagrams like these when looking at clinical trials. And so the Griffin trial compared the addition of daratumumab plus VRD or RVD versus VRD, followed by an autologous transplant, followed by consolidation that was similar to the induction, and then followed by maintenance chemotherapy. And what this trial found was by adding daratumumab to RVD, there were greater response rates, and the median PFS and OS at 22.1 months was not reached in both arms. So it's probably a little bit too early to tell whether there's a significant impact in terms of median progression-free survival or overall survival, just because there isn't enough follow-up data. And so one of the challenges with new research that comes out at conferences is we don't quite have enough follow-up data. Some side effects that occurred in the daratumumab arm were things like infusion reactions. Daratumumab is an infusion, and sometimes reactions can occur. There were higher rates of neutropenia, fever, low counts, but nothing that led to treatment discontinuation. So this looks like a potential promising upfront regime that could be explored going forward. The next trial I thought was interesting because it looked at the addition of two drugs that we often kind of save for the relapsed refractory setting. So this looked at people who are transplant eligible getting Revlimid, dexamethasone with the addition of daratumumab, carfilzomib up front, then having a stem cell transplant, then having consolidation, and then having maintenance rituximab. And they monitored MRD, or minimal residual disease, at various time points. And what they found was that there were significant MRD negativity rates the more treatment that you received. So after induction, so before the transplant, the MRD rates were around 34%. After the transplant, the MRD rates were around MRD negative rates were around 70%. And the best response of MRD negative was around 80%. So no patients who were MRD negative were found to have relapsed or found to be MRD positive, but there was only a small follow-up period of 7 months. And no patients discontinued treatment. However, as you can imagine, with the addition of more treatments, there's often more side effects to be on the lookout for, such as low counts, infections, and so on. So that's something to bear in mind as we bring new treatments up front. We have to monitor for side effects as well. And so to move on to the transplant ineligible population, so these tend to be patients who are a little bit older and may not be fit enough to are not fit enough to undergo a stem cell transplant. So these are patients who may have some heart issues, lung issues, that may have prevented them from moving on to having a stem cell transplant. And so there were some interesting studies looking at this group. And one was I like to call it I guess it's an OWL clone trial, but in my head I call it Frontline. And it looks at daratumumab VMP versus VMP. And so VMP is a very standard of care treatment that's used in the transplant ineligible population. So some of you listening in today may have been on VMP, and that's bortezomib, melphalan, prednisone. And then it looks at adding daratumumab onto that backbone. And what they found was that there was a 40% reduction in risk of death with a very long median follow-up time of 40.1 months. And so that was pretty significant, and I believe we're now looking at adding daratumumab up front in the transplant ineligible population, and it's working its way through various levels of provincial funding, because that's a significant reduction in risk of death. And there was also a significant improvement with respect to a progression-free survival, 36.4 months versus 19.3 months, and a better overall response rate as well. The HOVON trial looked at adding daratumumab to ixazomib and dexamethasone in patients who were unfit or frail. And so the patients in this trial tended to be older. The patients who were defined as unfit were patients who were around the age of, on average, 76, and the patients who were defined as frail tended to be 82, which was their average. And in terms of the progression-free survival, it was 23 months in the unfit group and 12 months in the frail group. There was a higher mortality rate in those who were frail, and they tended to be older with more comorbidities, but it was generally well managed with not a large rate of hospitalizations or infections. And so this is something that can be considered going forward in the unfit and frail group who are transplant ineligible. So I thought that was quite interesting. The next trial that I wanted to look at was the CONDOR trial that looked at adding daratumumab plus carfilzomib plus dexamethasone. And so daratumumab, as we talked about, is a monoclonal antibody that's directed against CD38, so it attaches directly to the myeloma cells. Carfilzomib is a drug very similar to ixazomib or bortezomib. So you can tell they all end in the same ZOMIB. They're all proteasome inhibitors. Carfilzomib is one of the most potent proteasome inhibitors compared to ixazomib and bortezomib, and adding that to dexamethasone. And this was used in patients who've had myeloma before, and it's now relapsed. And so in this trial, they compared KD, which is carfilzomib dexamethasone, to daratumumab carfilzomib dexamethasone, and they did MRD assessments at baseline at 0 months, 12 months, and 24 months. And what they found was that at the addition of daratumumab to carfilzomib dexamethasone led to the median PFS not being reached, and there being a 37% risk reduction of progression and death, which I thought was quite significant. Next, I wanted to move on to some immunotherapy agents that are out there that are quite interesting. And so I imagine that some of you have heard of CAR T-cell therapy, so I wanted to go through one of the emerging CAR T trials that was out there, and that's the CARTITUDE trial. And it looks at an agent called JNJ4528. And there were a number of CAR T trials that were presented at ASH. They were at various levels of development, and this was one of the landmark CAR T trials that was presented. And just a little bit of a primer of CAR T therapy, because I know it's been on the news a lot, and it's something that you've probably read about or heard about perhaps on the internet. And what it involves is CAR T therapy is kind of like a living drug that's designed using your own T cells. And so in our immune system, we all have T cells, and they help fight infection. And so what we need to do in order to do CAR T therapy is we need to do apheresis to collect your own T cells. And in order to do that, you're generally attached to an apheresis machine that looks very similar to a dialysis machine. Then these T cells are sent to the lab, a specialized lab where a gene is inserted in the T cell, and what is created is is that there's a chimeric antigen receptor as a result of the insertion of the gene that allows these cells to recognize myeloma cells. Then once the cell is created in the lab, they're then grown in the lab so that millions of CAR T cells are created. So your T cells are collected, their genes are inserted, a CAR is created, they're grown, and then they're infused back into you. Generally, before they're infused back into you, you do need some sort of lymphodepleting chemotherapy in order for the CAR T cells to work and populate your system. And then the CAR T cells are infused, and because of that antigen receptor that's been created, they recognize kind of like an address that surrounds the cancer cell. So imagine the cancer cell marked with little proteins on the surface of them. These engineered T cells identify them, attach, and then that causes the immune system to react and kill the T cells. So it's quite interesting. And then these cells continue to grow and populate. And so what we're looking for with CAR T cell therapy is the response rate, as well as how long do they actually work for. So we're looking for something with a good response rate, as well as a CAR T therapy that is durable. Some of the side effects that can occur with CAR T therapy, so as these cells are killing the cancer cells, there can occasionally be significant side effects. So some of these significant side effects can be fever, your blood pressure falling low, potentially an ICU stay, and occasionally neurological side effects such as confusion, delirium, difficulty speaking, difficulty writing, and we do have medications to help manage these side effects, but it's something to be aware of. And as more research is done on CAR T therapy, these side effects are better managed, and there are better protocols with respect to managing them. So what the CARTITUDE trial did, so off to the side there is kind of their algorithm of what happened with the trial. So they screen people to see if they're appropriate to go ahead with the trial, and that means that their heart is fit enough to withstand chemotherapy and collection, that there aren't really any significant baseline neurological effects. And then once you're felt to be fit enough to go ahead with the CAR T trial, then they were put on apheresis, which is where we collect the T cells. Occasionally, if the myeloma is growing quite quickly, bridging chemotherapy or radiation may be needed to keep the myeloma at bay until the CAR T infusion can occur. Because occasionally, if we look at that step where the millions of CAR T cells are growing, that can sometimes take weeks in the lab for this process to occur. And in that time where the cells are growing and being manufactured, you may need some bridging chemotherapy or radiation therapy to keep the myeloma at bay before the CAR T therapy is given to you. And so after we have the CAR T therapies, plus or minus some bridging therapy, these are largely done in hospital, but in the future may be done in the outpatient setting. Then you'd be given chemotherapy called cyclophosphamide and fludarabine to not completely wipe out the marrow, but to get a bit of disease control as well as stimulate the immune system, and then the cells are then infused. And there's a target dose in terms of how many CAR T cells are required, and generally it's around 1 million. Or it can be a little bit less than 1 million, but in and around that ballpark. And then after the cells are infused for the next 4 weeks or so, or 2 to 4 weeks, you'll be monitored quite carefully, looking at if there are any reactions such as fever, low blood pressure, any neurological side effects, and then you'd be followed up. And then followed up to determine whether the myeloma burden in terms of the protein levels has gone down. And so in this trial, there were 29 patients who were treated, and they had relapsed refractory myeloma. And what was great about this trial was that 100% of those 29 patients responded to treatment. And in all accessible patients, they were all MRD negative. So I think that's, a fantastic response rate. How often do we say that there's 100% response rate? Common side effects were those that we had talked about: cytokine release syndrome, so that's the fever, hypotension. And then as a result of the chemotherapy and the treatment, you can get low blood counts such as anemia, leukopenia, thrombocytopenia. What we don't know, though, because this is a trial and we're still getting follow-up data, and I believe the follow-up data that was presented only went out as far as 6 months, is how long the CAR T cell will work for. And so it may not be a cure, it may not be a durable response for years, but that is something that is being studied and looked at, and hopefully in time we'll have more follow-up data with respect to how long people remain in remission. So I thought that was very interesting. And so, yeah, so promising PFS results, more research is needed. We want to make sure that the CAR T cells last quite a long time. And then other questions that may come up in the future are, when should we consider CAR T therapy? So right now, they're generally being considered after 1 to 3 lines of treatment for myeloma. And so there's research looking into whether this treatment needs to move up front or whether it should move to first relapse. So I expect an explosion of CAR T trials in the future as the manufacturing processes are ironed out, the side effects and the management strategies are ironed out as well. So this is something that's quite promising. And I'm hopeful that the next upcoming years will be available in Canada for myeloma. Right now it's available for lymphoma, or access is available for lymphoma. However, research is still underway for myeloma. And so then I wanted to move on to some other new agents and combinations that were presented at ASH. And I wanted to look at Venetoclax in particular, and then we'll look at another anti-CD38 monoclonal antibody, TAC-079. It doesn't have a name just yet, but it will at some point. And look at some of the BiTEs that are emerging as well. And so the BELLINI trial I thought was interesting. It looked at a drug called Venetoclax. And Venetoclax is another drug that has a remarkable ability to target myeloma cells, and it can induce myeloma cell death. And so in this trial, placebo plus Velcade dexamethasone was compared to Venetoclax Velcade dexamethasone. And then patients who had relapsed refractory myeloma continued on this until there was disease progression. And what they found were that the patients who responded best to Venetoclax Velcade dexamethasone were those with translocation 1114. So you might remember when you had your first bone marrow at diagnosis, you may have been told of set of genetic abnormalities that you had, and a common one is T1114. And so the one patients who have 1114 tend to respond quite well to Venetoclax. What they found, though, with this study is that there is also an increased risk of death in those who did not have 1114, largely from infection. And so this is something that just needs to be examined a bit more closely in the future. And it may be that Venetoclax in the future is more tailored towards those who have translocation 1114. The next trial looks at adding Venetoclax to daratumumab plus Velcade plus dexamethasone, so a 4-drug trial. And then both of these regimes demonstrated a good safety profile. So Part A looked at Venetoclax plus daratumumab plus Dex, and Part 2 looked at Venetoclax, daratumumab, Velcade, Dex. Those who received all 4 drugs had a better response rate. So that's something that's encouraging in terms of another treatment option that's available in the future. And so this is a trial that looks at another monoclonal antibody, so very similar to daratumumab, so similar mechanism like daratumumab. So it's I like to think of it in my mind as a new daratumumab because they're a similar mechanism of action. And what this found was that it was a promising drug in those who were heavily pretreated in the past, received a number of different regimes, and it's also being looked at in combination with pomalidomide and dexamethasone. And it seems to also be effective in those who've received daratumumab in the past. The next trial that I wanted to look at is something called a BiTE, and it's a bispecific T-cell engager. And so how a BiTE works is that it's a molecule that has 2 ends, one that attaches to the tumor or the myeloma cell, and one that stimulates CD3 positive cells, which are T cells. And as a result, it activates your T cell immune system to attack the cancer cells. And so this is quite interesting. It's given in cycles. And there was quite a good response rate of 88.9%. All of the patients on this trial achieved a complete response, or the patients that let me correct that. And the patients that received a complete response or stringent CR, they were also found to be MRD negative. And then the next trial that I wanted to chat about is another agent that's quite interesting. It's called Belantamab mafodotin. I'm probably mispronouncing that. Often we kind of shorten it to Bella because that's just a little bit easier to say. And it's a monoclonal antibody drug conjugate. So half of it attaches to the BCMA, which is on the surface of the myeloma cells, and then the other half of this agent is attached to a drug. And so what happens is that as soon as it attaches to a myeloma cell, the drug that's attached to the other end of this antibody kind of shoots a drug directly into the myeloma cell, killing it. So prior phase 1 studies have demonstrated a 60% response rate using this agent. There have been some toxicities, including eye irritation, blurry vision. And so DREAM3 is a study that's currently ongoing, which looks at Belantamab mafodotin in combination with pomalidomide dexamethasone. So the results are not quite yet available, but it looks quite promising. So overall conclusions, we looked at a lot of studies today, and some of the themes are that we found that the 4 drug regimes, so those that had 4 drugs up front, like Dara, Rev, Velcade, Dex, seem to be more effective in terms of higher progression-free survival or overall survival than those that received 3 drugs. We saw that there were a lot of new immunotherapies that are available going forward, including CAR T-cell therapy, BiTEs, and those seem like quite promising. And then that there were newer generations of drugs being developed, such as new generation monoclonal antibodies, such as that TAC-079 anti-CD38 monoclonal antibody. We also saw that Venetoclax is a drug that works well in translocation 11-14 myeloma. So I just wanted to end off by saying that the future looks quite bright, as there are many new drugs currently in development for myeloma. And I just wanted to say that there are many more drugs that are available now that weren't available when I finished hematology training, and there are many more in the pipeline. So I think there are many reasons to be very hopeful and excited about new treatments in myeloma. And so at that, I just wanted to open it up to see if anyone had any questions, and then we would go from there. And I just wanted to thank you for listening to me on a Tuesday night, and we'll go from there. Thanks, Gabe, and thanks, everyone.
Thanks, Dr. Bhella. That was great. Lots and lots of information to digest. So I already have 2 questions that I've received. Before I get to those, I just wanted to remind everyone how to ask a question. So if you go to your GoToWebinar software panel, you have a little section here that says questions. And so if you just type in your question here where I'm showing you with the mouse and click on the send button, you'll be able, I'll receive the question and I'll read them to Dr. Bhella, and we'll do it that way. So for the first question, let me get to one of the questions here. Okay, so the first question has to do with CAR T cell therapy, and it has to, surprise, right? We have a lot of questions on CAR T cell therapy, but specifically with the trial that you presented, you spoke about an overall response rate of 100%.
Right.
Now, the question here is, if we have such a successful rate, then why isn't it yet standard of care?
Right, and that's an excellent question, and I actually expect that CAR T therapy will become available in Canada in hopefully 2021 or 2022. And why it's not yet standard of care is that this is an early phase study. And so generally we need studies that are phase 2 or phase 3 that compare CAR T to another agent in order to make it available on the market. Other things to note are that there are some significant side effects with CAR T therapy that need to be considered. Occasionally, patients can develop cytokine release syndrome that can lead to ICU stays, or neurological syndromes as a result of the infusion of these cells that can look like you've developed a stroke. And so highly specialized centers that have experience in administering CAR T therapy are needed in order for it to be delivered safely. And as we looked at through all of the steps that are required in CAR T therapy, there's a collection, there's the manufacturing of it, which is quite resource intensive. And so I guess this is a long-winded answer to say that a lot of resources are needed in order to develop the infrastructure to administer CAR T therapy. And there have been a lot of work across Canada in doing this. And I imagine that within the next year or two, this will likely become available. And some more studies are needed to just try and sort out some of the side effects. So hopefully that answered the question.
Yes, it did. Thank you. Our next question has to do with, it's more of a general question. We have all of these drugs that have, have been approved and available in Canada over the past few years. The question is, how has it impacted the prognosis of someone who's been diagnosed with myeloma?
So that's an excellent question, and I would say that it's impacted overall survival of patients with myeloma significantly. It's hard to measure the impact because a lot of the drugs have come on in the last 2 or 3 years, so it's not enough time to say it's improved overall survival by X amount. But if we look back 20 years to now, overall survival like 20 years ago was probably in the range of 6 months to 2 years, and now we're around 9 years, and I imagine that it will only get better as now we have more drugs available. Occasionally, as you receive more treatment, sometimes there are more side effects that can prevent like full administration of the drug, and that's something to consider. But I do think that this has definitely improved overall survival, and shortly we should have stats to back that up as well.
Fantastic, thank you. The next question, we talked about the one of the translocations in myeloma, and the question simply is, can we access genetic testing in myeloma in Canada?
Yes, so absolutely, that's an excellent question. So you can access cytogenetic testing in myeloma, and it's generally done at diagnosis. And so if you've had a bone marrow at diagnosis, your bone marrow is generally sent for cytogenetic analysis. And sometimes it can take a week, or not a week, but weeks to maybe 1 or 2 months to get the results back of cytogenetics, but you should be able to get results of your cytogenetics. Sometimes if you don't have enough myeloma cells in the marrow, the cytogenetics test may come back saying that there are no abnormalities, or the test was not able to be done. And so if you have less than 10% plasma cells in your bone marrow, you may not be able to get baseline cytogenetics, but I would say most people with myeloma would be able, or should be able, to get cytogenetics in Canada.
Okay, awesome. Thank you. Yeah, there's a few other questions. I'm just filtering through them here. At the end of the webinar, we kind of spoke about how, four drugs is better than 3.
Right.
Currently in Canada, do we have any 4-drug regimens available? And if someone is on 3 drugs, would adding a 4th drug potentially help them?
So that's an excellent question. So right now in Canada, I don't believe that we have easy access to 4 drugs. I do imagine that this will change shortly, as one of the trials we looked at VMP plus daratumumab. So that's upcoming in those who are transplant ineligible. So then there's the question of whether we add another drug if you're already on 3 drugs. Some of it is funding. We don't quite have the funding in place yet to access 4 drugs in Canada, but I imagine as some of these studies mature and there's more evidence, the access then follows.
Okay.
So I guess the answer is we don't have access for everyone just yet, but I expect that we will in hopefully sometime soon.
Okay, great. Thank you. So just I got a few more questions here. We're just going through it. Someone here is asking about genetic markers and families of myeloma patients. So, what's the risk of someone in the same family developing myeloma, and are there any genetic tests which would tell you that?
So myeloma right now is not felt to be a condition that's passed down from family member to family member. Occasionally we will see the odd family that has like 1 or 2 members with myeloma. There aren't any really specific genetic markers at this point in time to test your family, as it's not felt generally to be a disease that's passed down from generation to generation. But if your family member is ever concerned, they can always see their family doctor, and I would just really recommend having a routine CBC done. But other than that, I don't. There aren't really any genetic tests to look at this point in time.
Okay, thank you. The next question again has to do with genetic mutations. When someone is shown to have a genetic mutation, does that at all change the treatment that they might receive?
So that's an excellent question. So there are some genetic markers that are felt to be higher risk, and those are things like 17p, which is a deletion in a tumor suppressor gene. Many of the abnormalities with 14, like 1416, 414, are felt to be high risk. And then that, in some circumstances, can change treatment. So, for example, 414 is felt to respond quite well to a drug like Velcade. And so if you're diagnosed with like 414 up front, you generally would get, in Ontario, you would get Cyborg followed by transplant, and then likely followed by bortezomib maintenance rather than lenalidomide maintenance. So occasionally there are genetic abnormalities that can tailor your maintenance treatment going forward, or even some of your treatment choices going forward.
Okay, thank you. Now, the next question we have here is, we've been talking about, adding a new drug up front. And so the question is simply, what if, what's the difference between adding the drug up front and then instead of giving it at first relapse?
Right, and so our hope is that if we add it up front, there may be longer remission duration. So the hope is that if you're adding a drug up front, you may be in remission for many more years rather than if it was used at first relapse. However, because these trials are fairly new, we don't have all of that follow-up data. So right now, while we're waiting for that follow-up data, we're using the drugs later down the line. The other challenge is that more drugs that you receive, there's higher chances of toxicity. So there's a higher chance of side effects that then may prevent you from receiving the whole treatment regime, or that may lead to a emergency room visit with an infection. So the data are not quite mature just yet. We're just looking at them in abstract form. But as more time goes on, you can then compare some of these things in terms of was everyone able to receive full treatment? How many emergency room visits were there on this treatment versus another? How long was the remission? And then you can further answer those questions going forward.
Okay, thank you. Okay, so just a few more questions here. So the next question, if we could, okay, let's go for this one. So we didn't really talk about smoldering myeloma. Right. And so there were a few questions that I received regarding that. One of them is, what's the current standard of care for smoldering myeloma or high-risk smoldering myeloma? And the other question has to do with, what's the evidence saying so far about when treating someone with smoldering myeloma? What's the latest data there?
Right. So with smoldering myeloma right now in Canada, we've largely been just doing active surveillance and not necessarily treating the smoldering myeloma. Although there have been some studies looking at adding agents like lenalidomide to those who have high risk smoldering myeloma. However, it's hard to know if that changes the overall outcome. So right now, we've largely just continued with surveillance, but there is some emerging evidence in this area, but nothing that has changed practice as of yet. Okay. So I'm not sure if that quite answered the question.
I'm going to see if I get a clarification question. In the meantime, we could move on to another question here. Sorry, I just need to go through these again. Someone here is asking if there's been any new data that's been presented regarding allogeneic stem cell transplant and myeloma. instead of, yeah.
So there have been studies looking at allogeneic transplant in myeloma. Many of them are aimed at those who are younger and who have high risk disease. And so there have been some studies looking at auto followed by allo, or allo in those who've had multiple lines of therapy. However, an allo transplant has the potential for significant side effects, including a high risk of death, high risk of graft versus host disease. And so right now it's not used as standard of care in Canada. However, if because we have other lines of treatment that can be used that have less toxicity and lower risk of death. So it's not generally used as standard of care, but there are some centers in the States that will consider it following an auto transplant.
Okay, awesome, thank you. Another question, this is a more general question regarding the trials. And so all of these trials were presented in the US, but the question is, are there any, does Canada participate in any of these trials, and or are they just US trials?
So that's an excellent question. So Canada participates a lot actually in these trials. So at many of the academic centers in Canada and some of the community centers in Canada, you may be able to access clinical trials. So like things that are available at Princess Margaret, for example, there's been a CAR T trial that's been open in the past, some BITE trials. The DREAM trial that we looked at is available here. And so definitely Canadian patients are on these trials, perhaps not all of the ones that were presented today. And we do have a very robust Myeloma Canada research network that looks at developing trials in the Canadian context and recruiting patients who are Canadian to participate in these trials.
Awesome, awesome. So we'll have a few more, just one or two questions before we finish off for the night. You still good?
Yeah, still good.
Yeah. Okay. So this one here. Sorry, my screen is okay. So can you comment on or have there been any studies on how patients generally do when they are seen by someone who, or when they're seen at a center where there's a lot of myeloma happening versus treat a lot of people where there's a lot of experience with myeloma versus being treated at a center where there may not be as much experience with myeloma?
So that's an excellent question. I don't believe there have been any studies that I'm aware of that have looked at, outcomes of patients at smaller centers versus larger centers. I would say that like some differences that may be present are things like there may be better trial access because it takes quite a lot of infrastructure to run a clinical trial. So at a larger center, you may be able to better access like a CAR T trial or a BITE trial, and that may not be available at a smaller center. But you can always, ask if you're interested in a clinical trial to be evaluated at a larger center, or if you're interested in a clinical trial. That would be, I think, the big difference between a larger center and a smaller center.
Okay, great. Now the next question has to do with drugs and response to drugs. And so,
yes.
If someone doesn't respond to a multi-drug regimen, does that mean that those drugs can't be used again?
So that's an excellent question. So generally, if they don't respond to a multi-drug regime, they're probably refractory to those drugs. Sometimes we can retry it in a slightly different combination. However, if you're refractory to a drug, it likely won't be that effective. So for example, if you've seen 4 drugs and you're refractory to all 4 drugs, then that limits your treatment options going forward. So I think I agree with your statement that you made. Does that limit your drug access going forward? Yeah, probably yes.
Okay. Okay, awesome. I think I could maybe go with one more question here.
Lots of questions. This is great.
Yeah, just hard to filter through all of them. But okay, so let's go with. Okay, so this question has to do with one of the drugs that we talked about a lot today, daratumumab.
Yep.
And so I believe there's a trial ongoing, or several trials ongoing, where they, instead of giving it as an infusion, it will be an injection.
Yeah.
So this question basically is asking, do we have some kind of timeline or an idea of when it might be available?
So I'm not sure of the timeline when subcutaneous daratumumab may be available, because I know it does take quite a bit of time, in the chemo daycare chair, to have that infused. My hope is that it will be available within the next 1 to 2 years. However, I don't have a definitive timeline on that.
Okay, great. I mean, if we don't know, we don't know, right?
Yeah.
We need to.
I feel like I'm saying 1 to 2 years for most things, but I'm not entirely sure of the timeline.
Okay, great. So with that, I think we'll end the webinar. Dr. Bhella, thank you again so much for agreeing to do this, spending your evening with us.
No problem. Happy to do it.
I did receive many comments from our viewers who thank you and are very appreciative of all this. And as mentioned, the webinar is recorded. It will be available on our YouTube channel in a few days. And so if you have anything you'd like to review, please go to our YouTube channel or contact me, and I will be able to help you out there. So Dr. Bhella, thank you so much, and have a great evening.
You too. Thank you. Thanks for listening in.
Bye-bye. Thanks. Bye-bye.
Bye.